introduction. I am very excited to be here today. As you know, I'm a pediatric epileptologist, and just in general, it's very important for me to continue to advocate for my patients, for my families. The goal is always, better quality of life, reduce the seizure burden, make my patients seizure free and safe. Safety is most important. So, I'm hoping with today's talk, you take home something new, and you get to learn a little bit more about just in general different kinds of seizures, understand the difference between seizures versus epilepsy, understand that how does seizure first aid look like, what can we do to help our patients or our family members or our students who are seizing. Also, briefly, I'll touch base on like different kinds of rescue medicines that are out there and how to administer them and how to use them, and really trying to distinguish between when is seizure an emergency versus not, because it can be very scary when you have a family member go through a seizure and you really feel helpless. And so I'm hoping I can cover some good points about how to take care of them so you feel more empowered in your journey with your students, patients, family members, whoever has epilepsy or seizures in general. So I want to first start off by saying seizures and epilepsy go together, but they're not the same. And a lot of times, there are terms out there, seizure disorder. Sometimes people use epilepsy term. I think it's very important to have a appropriate diagnosis because that impacts your overall prognosis and how your journey would look like. Seizure essentially is just a symptom, just like you have fever when you have an infection. Seizure comes from the brain and it is a symptom and it is an event, whereas epilepsy is a disease of the brain. It's a disorder of the brain where you have an inherent risk for having more seizures, whether that is from several reasons I'll touch base on. And so that then you get a disease and you get a diagnosis that you have epilepsy. And now we need to talk about daily medication. So I think it's important to understand the difference between the two. Epilepsy is more common than we think. In US, maybe about 3 to 3.5 million people have epilepsy. And worldwide, the number is quite high, is about 65 million. If you look at the total world population, it still ends up being 3 to 5% of the total world population, but still up there. Tends to occur more in early childhood. So we have a lot of young children, about 500,000 currently, which have active epilepsy. There are about 45,000 cases each year that are diagnosed annually from epilepsy, and there can be up to 50,000 unexpected deaths from someone or premature deaths in someone who has epilepsy. So it has significant impact in our daily living. Some studies, when you look at more details, can go as high as 1 in 26 people may have epilepsy or develop epilepsy at some point in their life. And then if you really hone down on seizures, it's even smaller. So 1 in 10 people will have one seizure in their lifetime. So it is fairly common. It's important to understand it affects all ages, tends to be more in early childhood where you have new diagnosis of epilepsy, but there is another peak that is seen in older population around 60, 65 year of age where you can have new diagnosis of epilepsy that sets in. And it affects all individuals equally. So there is no, racial or socioeconomic distinction in terms of incidence of epilepsy. Of course, I think in terms of management and access to care, there is variable. These factors do play a role. Access to medicines, access to treatment options. There can be more severe forms of epilepsy, especially in developing countries where poor resources, lack of different kinds of medications versus some of the other countries that are more advanced and have a lot more resources out there. Epilepsy is one of the most common disease of the brain. It is more common than cerebral palsy, Parkinson's, other neurological disorders like muscular dystrophy or multiple sclerosis, probably not as common as stroke. Stroke is also very common. So, but epilepsy can be seen in people who have had strokes. Coming to what causes this epilepsy, and like I said, what does this epilepsy do really? It really increases your risk for having a seizure. So what is a seizure? A seizure is clinical manifestation, a symptom that you see or you may see on surface that comes from an abnormal excessive synchronization of different neurons in the brain. As you can see here, this is just a broad gross picture of what the brain looks like. When you cut it out, really the brain is divided into two main parts on the surface. That's your gray matter and your white matter. Gray matter is the one that's tiny layer on the top of the brain, or the cortex, it's what is called, is the one that has all these nodes that can generate seizures, or the neurons are clustered around here and they generate seizures. White matter, essentially think of it as wiring for the light bulb. So your neurons are your bulbs, and white matter is the lighting. And so when you have abnormal activity happening within these neurons here, the wiring will carry that activity to other areas of the brain, and then it gets all synchronized, and then you start seeing symptoms. That's why you can have seizures starting in one part of the body and then progressing to the other part, eventually involving the whole body. So it can be sequential. These abnormal electrical neurons, when they misfire, they generate electric current around them. And this is the current that we can measure objectively. So that's where anyone who has had seizures or has epilepsy, they end up getting something called as EEG or electroencephalography. So this EEG can pick up that signature of abnormal electrical activity in the brain, which gives us more information about what is your risk for having future seizures or not. And this electrical activity also has magnetic field around it. So that's where there are some nuanced testing, like a magnetic encephalogram or a MEG scan, that is sometimes done to get more further information in someone who has severe forms of epilepsy, and we are pursuing, other treatment modalities, especially surgery. The symptom of a seizure can be variable. So, see, there are many different types of seizures. It really depends on where in the brain the seizure is coming from. Our brain has several different lobes: frontal lobe, temporal, parietal, occipital. We've been able to map important function in certain areas of the brain. As you can see here, this is your motor strip, this is your sensory strip. And so if there is a seizure originating in this area in the motor strip, essentially the symptom that you see on the surface is from dysfunction in this area. So instead of regular movement, you'll see jerky, rhythmic shaking activity that is not suppressible. If you put your hand down, you can't stop it. So based on, where in the brain, the seizures can have autonomic changes with heart rate changes, blood pressure changes, like heavy breathing or not breathing, going apneic. You can have abnormal tingling, marching sensation in your body that goes from one side to another. You can have altered behavior, altered awareness, and then motor symptoms, like I mentioned. When it comes to epilepsy, essentially, it is a diagnosis where you have seizures, but when you have more seizures, so you've had no reason for why you had a clear reason why you had a seizure. You've had an unprovoked seizure, at least occurring 24 hours apart, that gives you a diagnosis of epilepsy. Another reason where I would diagnose someone with epilepsy is if they've had one unprovoked seizure, but when you do more evaluation as to why did you have a seizure, we get an MRI, we get an EEG, and there is an abnormal, structure in the brain, or there is very abnormal activity that I see on EEG that tells me that this child or this patient is going to be at more than 60% risk of having another seizure within the first 6 months, then they would get the diagnosis of epilepsy and may need to be on medication to prevent that seizure. Seizures can occur for various different reasons. These are usually provoked by something happening in your body or any injury to your brain. So if you have very high grade fever, you can have a febrile seizure, and this tends to happen more in children. Really starts around 6 months of age up to 6 years of age sometimes. So school going kids are involved, kids in preschool, daycare, they can have. And there are certain viral infections, especially like HSV, influenza, roseola, these kind of viruses. They tend to just irritate the brain a whole lot when they have that high grade fever, and that can cause a seizure. It's not an epilepsy. It's just one time, two time. You may have multiple times, you may have febrile seizure, but that's because of the fever. So we equip you with medication to help control it if there is a significant prolonged seizure, but there is no daily medicine that is required. And it has been shown that being on a daily medicine doesn't necessarily prevent your risk for having future seizures in terms of febrile seizures. Then you can have injury to the brain from like a traumatic brain injury, whether it was a car accident or you fell off the ladder, you have a significant bleed in your brain, you have a brain infection like meningitis that can increase your risk for seizures. Certain drug withdrawals or ingestion can also cause seizures. This is more commonly seen in the adults or teenagers. Sometimes cocaine, ketamine, a lot of street drugs, synthetic marijuana can increase your risk for having seizures that are provoked from the medication itself. Rarely, hypoglycemia, especially in severely diabetic patients, can also cause seizures. There are other metabolic abnormalities, like if you have low salt, low sodium, hyponatremia, or hypocalcemia, can also provoke seizures. When it comes to epilepsy, you have all those things that cause seizures will also cause epilepsy, but with an inherent risk of having seizures. So, of course, if you have had, brain trauma and that has led to a scar tissue formation in your brain, that might increase your risk for having long-term epilepsy. If you have a tumor in an area that is near the gray matter, like I showed, you can have an increased risk for seizures. Not all brain tumors increase your risk for seizures. If you have a brain malformation that you're born with, abnormal, the sulci or gyration where your gray matter is abnormal, that can increase your risk for seizures. Previously, as you can see, in 1975, we did not know. We only had reason for about 1/3 of the causes for epilepsy because the genetic testing, the imaging skills with the MRI were not that advanced. As the technology has advanced, a lot of these idiopathic causes of epilepsy have a diagnosis to them. Now we have understood that there are certain genetic mutations that increase your brain's connectivity, your neuronal functioning is abnormal, and that increases your risk for epilepsy. So, with advanced imaging, advanced genetic testing, we've been able to identify a cause for epilepsy in a lot of patients. Still, there, I would say 1/3 of them, up to 30% of them, we may not have a clear cause, even despite advanced genetic testing. But this is something that I think is continuing to get better with our ability and more. Now we do genome testing, we may be able to find answers even for those 30% where we don't have answers as to why they have epilepsy in the next few years. This is more common than we think, but it is still considered as a stigma in most places. And so I'm glad now more and more celebrities are coming forward to create more awareness about this disease. But it is, in especially a lot of developing countries, it is considered as a stigma. It is considered as a mental illness, and it is not a mental illness. It is not a psychiatric disorder. You can have psychiatric comorbidities, you can have intellectual disability in someone who has epilepsy, but that is not because of epilepsy. It can be because of, in general, the structure of the brain or the functioning of the brain. Uncontrolled seizures can worsen your cognitive abilities, and so we really try hard to try to control your seizures or treat your epilepsy. Another thing that's a common myth around epilepsy that it could be contagious. It is not. This is not something that is contagious. It can be inherited, but not contagious. There are other also myths that go around. Sometimes, we hear like you might worry about tongue being swallowed during a seizure. That is something that is impossible to happen. And so definitely we encourage, and I'll talk more about the seizure first aid piece, but if somebody's seizing, there's no need to put your hand in their mouth. They will not swallow their tongue. There are different kinds of seizures. All seizures may not involve convulsions. So it's important to know that seizures can be very different for different people, and understanding each individual's seizure type and epilepsy really helps the caregiver provide the appropriate kind of care. When a child or a patient is having a seizure, they may not be aware of them. So really, our history is so important to from a clinical standpoint in terms of providing appropriate care, and we rely not on the patient but on the caregiver. So what you observe when the patient is having a seizure, that is most important when it comes to trying to understand what is their seizure. The reason I bring up is because there are multiple different types of seizures. So it is important to know what is the kind of seizure the patient is having. Patient himself or herself may not know what seizure they have. They may not have any memory of the seizure that happened, but they might be able to describe events around the seizure. So there are broadly, two main types of seizures. One is a focal seizure, one is a generalized seizure. As the name suggests, focal seizure comes from a very small area in the brain. It can be in one a particular spot only, like if you have a malformation in this particular area, or you have a tumor there, or you've had a stroke there and there's scar tissue there, or it can occur from multiple different areas in the brain, especially in somebody who has genetic epilepsies. You may have, neurons clustered around variably in the brain that may not function right, and you can have multifocal form of epilepsy. And then you have generalized epilepsies. These tend to occur from a deeper gray nuclei, deeper gray areas in the brain, and often abnormal electrical activity appears as a one big synchronized burst of activity. So the entire brain gets recruited in the seizure pretty quickly, and this is a more dramatic type of seizures that you will see. Within the generalized seizures, there are several different types. So you can have generalized seizures that involve motor movements. Motor essentially means involvement of limbs, or change in the tone of the body. And then, or you can have non-motor symptoms where you don't have any movement, abnormal movement, and you're sitting just right, or you continue to walk, but there is an altered behavior and your altered awareness. So from a motor standpoint, there are different kinds of seizures. You can have tonic-clonic, you can have atonic, myoclonic, or epileptic spasms type of seizures. And then the non-motor types involve your absence, very commonly known as petit mal as well, where you're just staring and have a behavioral arrest. For your tonic-clonic seizures, again, this is the most common type of seizure that is advertised, that may scare people a whole lot, or is usually seen in the field. Can occur at school, can occur while crossing the street, anywhere. And so it's very easily recognized by people that this is a seizure. Involves multiple phases. Phases can be sequential. So tonic essentially just means stiffening. The word tonic means stiffening. And so that phase is probably what starts first, where you have stiffening, but you can have it reverse. You may start off with jerking. Clonic means jerking. So you may start off with jerking activity first and then goes tonic, or you can have clonic, tonic, tonic again, and clonic. Really, it can vary the intensity of the seizure depending on duration of the seizure. The longer the seizure lasts for, often, there is impaired consciousness and there is only mild clonic jerking. Always, in these kind of seizures, consciousness is impaired. The tonic phase can be so hard and so strong that it can result in injury. It can cause shoulder dislocations, it can cause tongue biting, it can cause jaw dislocation, depending on how stiff the body gets during the seizure. During the clonic phase, sometimes, you can also have tonic stiffening of your neck muscles and you are not able to breathe as well. Sometimes because of full body just shaking or being so stiff, the brain has brain centers that help with breathing, they are suppressed. So you may have some apnea during those events. So there might be some facial discoloration, turning blue, turning red as well. So these are part of the tonic-clonic kind of seizure semiology, can sometimes be confused with a heart attack or a stroke. Often post-ictally, the patient or the child or the adult, they're very tired, they're confused, they're disoriented, so it takes longer to recover. Sometimes it can take up to a day or two even to come back. Often patients sleep a lot because it can be so intense and can be so dramatic from your entire brain getting recruited to produce the seizure. Other generalized seizures, so your atonic, these are not so common in adults, but more common in the pediatric world. And this essentially just looks like a collapse. You're doing an activity, walking, and then you boom, you fall down, or your head drops down. Very commonly seen in children, unfortunately, can result in a lot of injury. They can fall to the face, flat on the face, bust their lip, hurt their forehead. School age is more common when these kind of seizures or epilepsy presents. Then you have myoclonic jerks that can occur at any point as young as in neonates, but also very commonly seen in adults. Myoclonic jerks are brief jerks, can involve one body or the whole, just the arms, just the shoulder shrug, or like one arm or both arms. Epileptic spasms are similar to jerks, but they are more sustained and they tend to happen more in clusters. So they can be more intense appearing. It looks like the head goes down, both arms come up. So that's like an extensor spasm, or like an ab crunch, like a flexion movement of your arms and legs. So that's called like a flexure spasm. And you can have eye rolling with it. You can have a head bob with it. Often they tend to occur in cluster, usually in the mornings, or like anytime you wake up from a nap or as you're falling asleep. And the absence kind of seizures, so these are the more common ones that were previously called as petit mal. Again, tend to occur mostly in just childhood, but can start in young teenage years as well. Very rare to have absences come up in adulthood. And so it's mostly a childhood epilepsy. These are very brief seizures. It can last 10 seconds, 20 seconds, 30 seconds long, can be easily missed, can be very subtle, just involves staring, like I'm talking to you and I pause for a few seconds and I have a little bit of eyelid flutter, and then I'm back at where I stopped and I take off from where I stopped at. But these are very disabling because you can understand if the frequency of these sometimes can be, 30, 40, hundreds of brief seizures a day. You are missing information in that time frame when your brain is seizing. So often, you'll see children just declining in school, or teachers complaining about daydreaming and not doing as well at school as they were doing before. So it's worth an evaluation. It does respond to treatment sometimes. Sometimes it can be difficult to treat, but it needs to be evaluated for. Then you have your focal seizures. Now, focal seizures can have variable semiology, like I mentioned earlier, depending on which part in the brain they are coming from. You can have focal with impaired awareness, where you are not responding, somebody's talking to you, you cannot respond back. You may be able to hear them, but you're just not able to respond back, involving just jerking of one arm or the other. You can have also focal seizures where awareness is intact, where you are aware of your surroundings. You just feel like an abnormal sensation coming on. And so that can be part of a seizure as well. Again, it really depends which part is involved, but mostly, the symptoms can be variable. Symptoms can be sequential. So may start off with like feeling like a weird sensation in the stomach, and then go to staring, abnormal chewing movements, automatisms is what we call them. So people may pick on their clothes, be restless, turn around in circles, just sometimes take off their clothes because they have such altered behavior. Sometimes, walk away and don't respond when you call them. And then with the impaired awareness ones, usually you may have like an aura kind of a feeling, something in your stomach, feel like nauseous, tingling, numbness. You may have a feel of doom or an out of body experience as well, or you may see colors, you may see rainbows. So it can be very variable as to what your symptom can be. It is very important, I think, to take videos of seizures. It helps the caregiver, your medical professional that you see, helps them distinguish between the seizure types. As a caregiver, it's not you don't have to really figure it out all by yourself, whether it's focal or generalized. But if you can provide description of the seizure, if not, a video is very, very helpful. Seizures tend to have some phases to it, a pre-ictal phase, an ictal phase, and a post-ictal phase. Pre-ictal is usually that aura that will help us distinguish between focal versus generalized. Ictal, of course, during the seizure, what they're doing, and post-ictal is also sometimes very helpful depending on what their symptoms are. Sometimes you may have all vague symptoms, just tiredness, headaches, dizziness, but sometimes you may do repeated things like a nose wipe, always with your left hand. So something on those lines are always helpful for when you bring that information, and it helps us distinguish between the different types of seizures so we can treat it better. It's also important to understand that epilepsy is a spectrum. You may not have the same kind of seizures that you were having 2 years ago. Being on medications may change your seizure semiology. You may have more than one type of seizure within the same epilepsy syndrome. So, not every person has the exactly same kind of epilepsy. Not every person has the exactly same response to treatment. So, everybody's journey is very variable. Understanding each individual's epilepsy is very important to give the right kind of treatment for that individual. So that everyone needs more individualized care and individualized treatment plans. Understanding common triggers for seizures are important. You'll be surprised that the more you start thinking about it, then you'll clearly be able to recognize certain patterns. And if you avoid these triggers, the overall seizure burden does go low. The goal for treatment obviously is to get you to a point where you have enough, support assist like enough treatment in your system to prevent these seizures even despite the triggers. But sometimes it's hard to maintain that balance, especially with medications, and so just recognizing trigger is most important. Very commonly found trigger is missed medication or late medication dose. I think this is very easy to understand why, because your brain, now you have abnormal electrical activity happening which is being suppressed by a seizure medicine, and as soon as you stop miss a dose, that there is a variation in that, and that can suddenly cause a withdrawal kind of a seizure because your brain does get used to that. So missing doses, often I recommend, like, say you forgot your dose in the morning, what do I do? It's 12 p.m. now, can I take it at lunchtime? Just take it. Take it whenever you remember you missed your dose. If there is, you will not overdose by doing double the dose. You will overdose by doing 4 times the dose, but not by taking an extra pill a day. So I think that is something important to remember. Then there are certain kinds of epilepsy that are sensitive to light. So flashing lights, if you have photosensitive epilepsy, you may want to be aware of that. Again, with flashing lights, it's usually high frequency lights that can trigger, like strobe lights. Sometimes as simple as like just, as you're driving through and you can have flickering lights coming through a sunny day. Wearing sunglasses is a simple way to prevent these kind of seizures. And so protect yourself, use blue lens, don't sit too close to the TV. Sometimes video games, when you're sitting very close to the TV and it is flashing, that can trigger seizures in some patients. Stress and anxiety is a common trigger. Unfortunately, stress and anxiety goes with epilepsy because the nature of seizures are so unpredictable, but it is important to manage that. Anytime you're stressed out for various, personal reasons, that can definitely increase your risk for seizures. Hyperventilation can increase your risk for seizures, and especially the absence kind of epilepsies. Lack of sleep is a very common trigger. So often, like our teenagers, young adults, kids in college, this is one of the most common reason that they end up having breakthrough seizures is because they were up all night, they woke up early, and sleep deprivation, or you've gone camping. Sleep deprivation is one of the very common risks. In females, hormonal changes can also trigger seizures around the menstrual period. So that is also well known, and we can work around the treatment if you have that kind of trigger. So it's important to communicate communicate with your healthcare provider about that. Any kind of illness can be a trigger for a seizure. If you are sick with a cold, even though the fever is not that high, but you have inflammation in your body, you're not feeling good. Sometimes even constipation, your brain and gut are connected. If you don't feel good, it can certainly trigger seizure in the brain as well. There are other not, also triggers, overheating, very common trigger, overexertion. I live in Georgia. I see this all the time, especially in the summer months. Out all day playing, dehydrated, overheated, that can trigger a seizure. And then certain medications like can trigger seizures. Benadryl is a common one that we use for cold. So I definitely recommend avoid using Benadryl unless you really have to use it for an allergic reaction. Use that because the benefit outweighs the risk. But otherwise, avoid using Benadryl like a sleep aid or things like that to that daily use that can increase the risk for seizures. Other things like vaping has also been known to increase your risk for seizures. So when it comes to treatment, there are several different ways to treat epilepsy. Most common and most easy treatment is medication. When I say easy access, it's very hard to take a daily medicine. It is a commitment, and as a parent to give your child a medicine every day, or even as an individual having to take a daily vitamin, it is very hard to maintain that compliance, regardless, vitamin or blood pressure medicine or whichever medicine that you're on. So this is not easy. This is hard, but it's easy to start, easy to get, easy to access. It is easier than dietary therapy. Sometimes, if the medicines are not as effective, we can do different kinds of dietary therapies. Now, these dietary therapies are specifically for treatment of epilepsy, so I'll talk a little bit more about that. When medications or dietary therapy, or say you have a lesion in your brain that we know this is why you're having seizures, are not helping, then surgery can be sometimes curative. If it is a certain area that the seizure is coming from, we are able to figure it out exactly where it's coming from, and it's not an important part in your brain, we can easily take it out. We have a lot more brain tissue than we need, and so not every part in the brain is performing important function or activity. So surgery can be very safely performed in different areas in the brain. And when surgery is not an option, there are also devices that we know seizures do generate or eventually occur, or the neurons do generate abnormal electrical activity around them. And so this electrical activity can be modulated by an external current. And so these devices work with that kind of platform where they modulate that electrical activity in the brain and eventually help control seizures. Overall, if you treat it appropriately, you can have 50% of the individuals have very good control of seizures, will remain seizure-free. Some will grow out of their epilepsy, can be weaned off of medicine. If you're 10 years seizure-free or 5 years seizure-free, you're weaned off of your epilepsy, and you can fairly say that you've been cured of your epilepsy. There are still at least 1/4 of population where seizures are uncontrolled despite different treatment options, and they tend to be more refractory medically or surgically. Coming to anti-seizure medicines, we have a lot of options. There are about 30 drugs in the United States that we can use to treat different kinds of epilepsies. Every day, there are new discoveries in terms of new kinds of drugs, new clinical trials to design medications. And more so now, it's very rare, but certain genetic mutations, especially like with Dravet syndrome, we have been able to find a gene modulating drug that might work. Again, very early to say, and still in just beginning to get into phase 3 trial, but there is hope that we can go into precision medicine one day and we can cure someone's genetic epilepsy as well. So we are making progress. When it comes to medication, important to find the right kind of balance. All of these medicines work on the brain, right? So of course they will have some side effect or the other, and often the type of medicine that works for the epilepsy really depends on the type of seizures you have, whether you have focal epilepsy, whether you have generalized epilepsies. There are certain drugs that work better for one particular type of epilepsy. And then it also depends on your ability to tolerate the medication. You may have some side effects, sleepiness, drowsiness, dizziness. I mean, sometimes headaches. These are more commonly seen side effects for majority of the seizure medications. That's where working closely with your healthcare provider, finding the right fit for you is very important. That communication is very important because this is something that you will commit yourself for a year or two, or maybe longer, depending on what is your epilepsy type. And so having that communication, often when we do medications, we are not starting high doses right off the back, and it's a journey. Some people don't need as high of medication dose. Some people need much higher doses than the other. So that communication is important. If you're still having breakthrough seizures on your current medication, that means something needs to change. Either your dose needs to be optimized, or this medicine is just not working for you, and you need to think about something else. So it's important to understand that sometimes one medicine is not enough. You may need more than one medicine. You may need a combination of couple different medicines that may work better together. So there is a lot you can do with seizure medicines alone. Um, coming when seizure medicines are not as effective, you've tried 2 3 medicines now, you're still having seizures every few times a month, and it's not good seizure control, or you're having significant side effects from the medicines, then there are other options. There are certain genetic mutations that diet is the only best treatment, and so especially with like GLUT1 deficiency, pyruvate dehydrogenase deficiency, so there are certain metabolic conditions where ketogenic diet is your only treatment. So you would do it just to help control seizures and with the brain development. But this diet essentially has multiple variations to it. It depends on the amount of fat in your body versus protein and carb ratio. The idea is to train your brain to use ketones for energy instead of glucose for energy. Right now, on a regular diet, we use glucose for energy. Once you have ketones in your brain, that ketone or the state of ketosis, where your brain pH is slightly lower or acidotic, tends to help potentiate that inhibition of seizure activity. And that's how it tends to work. So it helps with the GABA or the inhibition network in the brain. It is a commitment. It is not something that you can be on for a week, try it out. If it doesn't work, then go back to your regular diet. No, just like with seizure medicines, it is a commitment. Sudden change in the diet may cause breakthrough seizures. When we first start someone on diet, we at least require 3 months to see any significant benefit from the diet. So the effect is not immediate, the effect is gradual. And if there is effect, typically we stay on the diet for a while, 2 years or more, depending on the type of epilepsy you have or the reason that you have epilepsy. Needs a strong support system to do the diet at school, at home. That commitment is very important. A lot of times it ends up happening for some of my patients that the diet is helpful, the entire family changes their diet. And so it takes a village to commit to the diet as well. It is a medical treatment, it's not just a fad diet. And it has shown benefits in certain kinds of epilepsies. Surgeries, multiple different kinds of surgeries are also available, and this you delve into surgery when you have a lesion or if you develop medically refractory epilepsy. That means if you've had tried 2 3 different medicines and you're still having seizures, even though your brain looks normal on an MRI, there are certain medical options, surgical options that we could consider because they tend to work more superior than your fourth, fifth, sixth, seventh seizure medicine. We know after some point, seizure medicines just don't work as well as you would like them to work. And when it comes to surgery, there is resective surgery that is curative. If there is a small lesion, we can figure where it's coming out and we can take it out. And then if it is something that you have a diffuse brain injury, diffuse brain malformation, you can often do palliative surgeries like disconnections that can lower the intensity of seizures, that can prevent you from falling, like the ones with the atonic seizures where you just collapse to the floor. We can do disconnection and you will not no longer fall and hurt yourself. So there are a lot of things, and these are very well tolerated. And when we think about brain surgery, it's better to go to a level 4 epilepsy center that can do the advanced testing that is required to do brain surgery. The goal is to reduce your seizure, make you seizure free, reduce the seizure intensity while keeping it very safe. So it is a process, it involves several steps. And then last but not the least, there are different kinds of neuromodulation techniques that can be offered through surgery. So quickly, because I want to spend some time on seizure action plan, which is most important. But with neuromodulation, there is a vagal nerve stimulator, which is a device that goes to stimulates a nerve in the neck, and this nerve basically takes current to the brain and then eventually helps lower the seizure activity in the brain. There is a responsive neurostimulation device that you implant in the skull. And here with this device, it's a little more nuanced device because it has electrodes that you implant within the brain. So if this is your area that your seizures are coming from, but when we looked into it, this is also important for your language. We will obviously not take it out. What we can do is we can put your electrodes here. It can capture the seizure. It delivers the current through this device, so it stops the seizure. So it's a closed loop kind of a communication. It works only when it notices that there is a seizure that's coming on. So it's a very, very nuanced device. There is another device called DBS, or deep brain stimulation, which works similarly to the vagal nerve stimulator, but more advanced in the sense that vagal nerve stimulator your vagus nerve really carries the current to the thalamus through the vagus nerve. Here you're implanting electrode directly into the thalamus in the brain. And this is again a very age-old device, has been used for several years, 50 plus years, for other reasons like movement disorders like Parkinson's, essential tremors. And over the last 20 years, it has been used for epilepsy. And over a period of time, tends to continue to work to improve seizures, all kinds of seizures. It is also invasive and approved for adults 18 and above. So now coming to see what we can do to help someone who's having seizures, right? Like 1 in 10 people will have a seizure. So how can we respond? First thing is just understanding that you want to distinguish, is this someone who already has epilepsy, or is it someone that is this a new seizure? Just provide care, essentially protect the person from any kind of hazard in their surroundings. So move them to a safe location. Provide the support, stay with the person till the person comes back to full awareness, or if there is additional help that's needed, you should be able to call for help. And then it's important to document, like, how long did the seizure last for. So when you have someone actively seizing, you want to put them in a safe place, preferably on the floor. Always turn them to the side. The reason being, you can have vomiting that can happen during as a part of a seizure. When you turn someone to the side, there is less chance of choking on that vomit or aspirating that vomit. And so you want to switch them to one side. Also, remove any kind of harsh objects that might be in the way. Like if they have glasses on, remove that. If they are holding something sharp, take it out of their hand. Do not put anything in their mouth. They are not going to choke on your tongue. Even if their jaw is clenched in, you don't have to try to open it, because you trying to put your hands in will just injure you. It's not like they will be able to open that jaw. Sometimes it's helpful to also support their head, because they can have the shaking that is not being controlled. So they can hurt their head with it. It is very scary to see a patient actively seize. So it's important to stay calm, stay collected. We often forget the time when we watch somebody seizing. A minute can feel like an hour. And so really important to actively time the seizure, because a lot of times seizures do stop on their own, and it is the timing of it, is duration of the seizure is very important when it comes to using your rescue medicine. And I'll talk a little bit more about that. But another, like I had mentioned, important to see if there is a bracelet or not, if the patient is a known epileptic versus this is a new seizure. If it's their first time seizure, it's always helpful to call 911 to do a more detailed assessment, because it could be anything. It could be a spontaneous bleed in the brain that may have triggered their first seizure, which is very rare, but it could be. So it's good practice to call 911. Do nots, which I already spoke a little bit about. So do not hold the person down or try to stop his or her movements. Just provide support. Do not put anything in their mouth. Do not give breaths. I mean, if even it appears that the patient is turning blue, not being able to breathe, the giving mouth to mouth is not going to help because the patient is not necessarily trying to take a deep breath. What really helps, if you have access to an ambu bag, you can give passive breaths through an ambu bag, but mouth to mouth doesn't necessarily help. Once the seizure is over, their breathing will get regular again. And the apnea during a seizure is so brief that it does not necessarily cause increased risk of anoxic brain injury. In some patients, apnea may be a very significant symptom of their seizure. So, and especially in children who have frequent status epileptic events, in those patients, I have often prescribed an ambu bag to the caregiver so they can at least do passive ventilation if the seizure is long or if apnea is their biggest concern during the seizure, and that's the only big main symptom. Do not offer anything to eat or drink until the patient is back to themselves and fully alert and cooperative and coherent. With focal onset seizure, your seizure response will be different, really depending on what kind of seizure they have. Again, focal is not as convulsive, so the injury to the brain part of it is not as significant. Depending on the duration, most seizures do stop within the 2 minutes. In some cases, the focal seizures can go on to develop the generalized bilateral tonic-clonic shaking. So you have to really gauge for the patient what is their seizure type and treat and time it accordingly. Same things, do not restrain. If the patient appears confused, just provide support. Make sure you are seeing if they can respond to you or not respond to you. Stay with the patient until they're fully alert because they may not remember. They may feel like they got to a place they didn't know they were at. They may be very confused afterwards. When does it become an emergency? So, first time seizure could be a medical emergency. It's worth considering calling 911. If it is a convulsive tonic clonic seizure lasting more than 5 minutes, that just means there is a very high chance the seizure is not going to stop on its own. It needs a medication to stop on its own. The longer you stay, and it's not necessarily 5 minutes of tonic activity that is can be damaging to the brain, but it is 30 minutes of continuous tonic activity, clonic activity that can be damaging. But for the purpose of controlling the seizures, we know that if it hasn't stopped within 5 minutes, it's very unlikely it will stop on its own. So you need to consider giving rescue medicine at this time. So it is still considered medical emergency in clinical practice on the field. If you have seizure clusters where you're having repeated seizures, without regaining your consciousness. If if you're having multiple seizures in an hour or seizures have changed, it could be an emergency. If somebody is pregnant, it could be an emergency, or has diabetes, it could be from hypoglycemia that needs to be corrected. Otherwise, there's risk for permanent brain damage. And of course, if it is in water, you need to really think of it as an emergency. Pull the patient out of the water, reposition in a safe place. If they're not breathing again, not coming back to themselves, then you want to call 911 and follow the seizure action plan. I'm going to quickly skip through this to discuss the seizure action plan, but there are certain things you can do. While if someone has epilepsy, is if you're in a shower, always take showers, don't take tub baths. Again, you can drown because seizures are so unpredictable. But don't lock the door behind you. Use a shower curtain instead of doors. In your bedroom, don't have a lower bed, have a lower or sleep on the floor. If there is a monitor, wear your seizure monitor if you have risk for tonic clonic seizures, so you can alert someone. For your kitchen, again, if you have myoclonic epilepsy, you have an increased risk for burning yourself, then you may want to be a little bit safe, use microwaves and things like that. A lot of these are common sense precautions that we need to take. Coming to rescue medicine. So, when you have a seizure emergency, you need to consider rescue medicine. And rescue medicine is something that is used as an acute treatment when the seizure is lasting longer than the normal time, 5 minutes or more. Or in some cases that I know, this patient is always going to have a status epilepticus and the seizure is not going to stop on its own, then I do recommend giving rescue medicine even at the onset. So it really is an individualized seizure action plan. I cannot stress on it enough. It really depends on the patient's type of seizures. This is a medicine for as needed use only because it's not a daily medication. It's not a place of a daily medicine. And these are regulated medications, so can only be prescribed by healthcare providers. So they belong to the family called benzodiazepines of the medications, and they are quick acting. They abort the seizure very quickly. There are different types. So there is diazepam, midazolam, lorazepam, clonazepam. You can see they all sound similar. Clonazepam is a tablet that can dissolve. It's a dissolvable pill. Diazepam comes in two different forms. You have your rectal form and you have inhaler form, nasal form. Midazolam is also available. So in the EMS uses it as injectable in the muscle, but at home we have some options where you can use the nasal form. So diazepam very commonly used seizure rescue medicine in children. So a lot of school nurses use this. A lot of parents use it at their home. You can use as young as FDA approved for 2 years, but after a certain, like maybe 10 kilo weight, 8 kilo weight, I've prescribed it in children younger than that as well, depending on the ability of the provider to give the medicine, the type of seizure that the patient has. It's a rectal medicine, right? So the way you implement is you want to, if you notice someone actively seizing, that is an atonic-clonic seizure, or this is an atypical seizure for them, and it's tonic-clonic, you may want to time it first depending on what your healthcare provider gives you the time. Typically, for most people, it is 5-minute mark. Again, like I said, some people who have a higher tendency to go into status, it can be as less a 2-minute mark. So really variable patient to patient, but typically 5 minutes. You want to open your butt cheek, you put the medicine in, push the plunger. You can see this is the plunger. The medication dose is typically written on this side. And once you've pushed the plunger, this is a single-use medical treatment. So once you push the medicine in, hold the butt cheek together at least for 5 minutes. It can take up to 5 minutes for the medicine to actually get absorbed through the anal mucosa and work in the brain. So just keep holding that butt cheek and provide the support. Some in older patients, young adults, it is very hard to do rectal insertion of medication. So you can use a nasal spray, and diazepam comes in a nasal spray form as well. It is approved for 6+, so ages 6 and above. So if you have, young school going, middle school kids, nobody wants to go through that experience in public having put rectal, and so nasal method may be preferred. Again, dose is weight dependent and age dependent, can be administered by anyone, comes as a single pack. Sometimes, depending on the dose, you may get two inhalers with it. So you have to use one in one nostril and spray the other in the other nostril. Always good to give during the seizure when it's lasting, because it may sometimes burn the nasal mucosa, is what I've heard. If this patient is back, coming back to themselves, and you've put the medicine in, so they may be more aware of it. Similar to Valtoco is Nasolam, which is the inhaled midazolam spray, again approved for 12 years and above. Single-use treatment, just like that, pre-packaged, so you cannot worry about dose errors. It's easy to apply. One dose usually for anyone above 12 years of age. And like I mentioned this briefly, but this is a seizure action plan, and I want to spend a little more time. I think I have like maybe 2 more minutes left. So I want to really emphasize on this. We did a study at our center for anyone, like for all the ED visits for people for seizure emergencies. Majority of the patients who came to the hospital had epilepsy, so known diagnosis of seizures, so epilepsies. So this is not like someone with a new onset seizure. They all had rescue medicines, but they did not have and we looked into what are the possible barriers that these patients are having to come to the hospital for breakthrough seizures. And main thing was that we found is, of course, is limitation in terms of understanding how to administer rescue medicine, but also having a seizure action plan was something that was missing. Majority of patients had rescue medicines at home, but just did not know how to use it or when to use it. So seizure action plan is very important. It is very individualized. It should be individualized. It is It is a paper that would have information about the patient, their types of seizures, their common triggers. This is something that you come up with a plan with your healthcare provider, with discussing that individual patient as to what works for them, what is their epilepsy. It may be possible they've tried diazepam, it doesn't abort their seizure, so we have to now use midazolam. So it has to be very individualized. This is something that schools require across different states. There are different kinds of seizure action plans schools require, but they require this plan to administer these kind of controlled medications in the school. And it's also something that adults should require sometimes at their workplace, and they don't often use it, but they should have it. As you can see here, you have your patient information, you have your triggers. Important to know what type of seizures. If someone is having 30 absence seizures in an hour, do I need to use a rescue medicine? Probably not. These are brief. There is no loss of consciousness. The patient comes out of it and comes back to walking and doing their daily activities. But if someone is having a tonic-clonic seizure, more lasting 5 minutes, yes, you have to use it. There are different phases to it: red zone, yellow zone, green zone. If you have someone with asthma, it's there, they have a similar kind of an asthma action plan, again, to help control the symptom. Depending on where the patient is. Green zone is essentially where you're providing your seizure first aid. Make sure the patient is safe, turn them on the side, don't put anything in their mouth, don't restrain them. Then you see if time the seizure, if the seizure is lasting long, you give the rescue medicine. Again, it takes time to even go and bring the rescue medicine. Sometimes it's just better to have rescue medicine handy if you notice someone is having seizures, so you can give the medicine on time. And say you've given the medicine and you're still not coming back to yourself, and the seizure has not aborted, or the patient is going back into another seizure, then that's your time that you want to call 911. And so very individualized plan. There is a healthcare provider that needs to sign off on it. In certain places, like in Georgia, we also need the parent to sign off on it for school. So different places have different kinds, but this is how most seizure action plans look like. And there is one that's available on the Epilepsy Alliance website as well. If your program or your school doesn't have it, or you want to use it for your workplace. So it basically equips someone to know what kind of epilepsy you have and be able to provide the right care for you when you're actively having a seizure. So it's very critical. And I think that is the end of my talk. This is just different members of the Epilepsy Alliance America network. I think it sounds like we are trying to expand, have more members join our community that is really focused on advocacy, empowerment of our patients and families to deal with epilepsy, and work together to help improve care and quality of life for our patients and families. So I'll end my talk here. Thank you, everyone. I'm